After emerging from the intervertebral foramina and traveling laterally atop the grooved transverse processes of the cervical vertebrae, the 5 roots of the brachial plexus, C5 through T1, descend towards the first rib, above which they combine to form the 3 trunks of the plexus. The upper 2 roots combine to form the superior trunk, the lower 2 roots combine to form the inferior trunk, and the middle root simply continues as the middle trunk. As the trunks pass over the first rib and under the clavicle, the fibers within them regroup and form the 6 divisions of the plexus, 3 anterior and 3 posterior. It is at this level, the level of the divisions, that the ultimate destination of all fibers is determined. The nerves derived from the anterior divisions will innervate the anterior aspect of the upper extremity, whereas the nerves derived from posterior divisions will innervate the posterior aspect of the upper extremity. After a very short course, the fibers within the divisions recombine to form the 3 cords of the plexus. The 3 anterior divisions combine to form the medial and lateral cords, and the 3 posterior divisions combine to form the posterior cord. Each of the 3 cords of the plexus becomes or contributes to one of the major nerves to the upper extremity. But before doing so, each gives off another major branch. Thus, the lateral and medial cords give off as their major branches the muscular cutaneous and ulnar nerves before combining to form the medial nerve. Similarly, the posterior cord gives off as its major branch the axillary nerve and then continues on as the radial nerve. In its passage from the neck out into the axilla, the plexus has a changing relationship with the subclavian and axillary arteries. At the level where the roots join to form the trunks, the plexus is joined by the subclavian artery, which crosses the first rib in the subclavian groove just anterior to the plexus. Then, after passing under the clavicle into the axilla, the artery, now the axillary artery, occupies a central position with relation to the 3 cords, which lie medial, lateral, and posterior to the artery, as their names imply. Critical to the concept of plexus anesthesia is the fact that the brachial plexus, like most of the major plexuses in the body, passes between 2 muscles, and hence may be considered to be invested by the fascia of these muscles. Above the clavicle, the roots and trunks of the plexus are sandwiched between the anterior and middle scalene muscles. The middle scalene muscle arises from the posterior tubercles of the cervical transverse processes of the lower 6 cervical vertebrae and inserts on the first rib just posterior to the subclavian groove. Since the subclavian artery and inferior trunk of the plexus cross the first rib in this groove, the insertion of the middle scalene muscle is just behind and in direct contact with the trunks of the plexus as they cross the first rib. The anterior scalene muscle arises from the anterior tubercles of the 3rd, 4th, 5th, and 6th cervical transverse processes and inserts on the first rib just anterior to the subclavian groove, separating the subclavian artery from the subclavian vein. The fascia covering the scalene muscles is derived from the prevertebral fascia, which splits to invest these muscles and then joins again at their lateral margins, forming an enclosed space around the plexus, the interscalene space. Thus, it is the posterior fascia of the anterior scalene muscle and the anterior fascia of the middle scalene muscle that constitute what we as anesthesiologists refer to as the sheath of the brachial plexus. As the neurovascular bundle, the plexus, the artery, and the vein, passes over the first rib and under the clavicle, it invaginates the prevertebral or scalene fascia, which continues into the axilla, forming the axillary perivascular space, a tubular extension of the interscalene space. The axillary artery occupies a central position with respect to the three cords. However, while the cords are named medial, lateral, and posterior because of their positions around the artery, they do not achieve these positions until the second portion of the axillary artery, that is, the portion which lies behind the pectoralis minor muscle. By gradually rotating around the artery until, in its second portion, their positions do become truly medial, lateral, and posterior, as their names indicate. It is at the lateral edge of the pectoralis minor muscle that the cords of the plexus give rise to the terminal nerves. However, unlike the rest of the terminal nerves, the musculocutaneous and axillary nerves leave the sheath as soon as they are formed. The musculocutaneous nerve arises from the lateral cord and leaves the sheath immediately to enter the coracobrachialis muscle, in which it continues to travel throughout most of its length. The axillary nerve arises from the posterior cord and leaves the axilla immediately by way of the quadrilateral space formed by the humeral neck, the teres major and minor muscles, and by the long head of the triceps muscle. The musculocutaneous and the axillary nerves are not in the sheath with the rest of the terminal nerves derived from the plexus. The intercostobrachial nerve, on the other hand, never does enter the sheath, but travels instead parallel and superficial to it. The medial brachiocutaneous nerve usually does likewise, though occasionally it is contained within the sheath. So if anesthesia in the distribution of these two nerves is desired, they will have to be blocked separately by subcutaneous infiltration just over the arterial pulse. It is interesting to note that where the brachial plexus terminates in the distal axilla, it is again sandwiched between two muscles. It lies between the coracobrachialis muscle above and the long head of the triceps below. Thus, as it passes through the axilla, the neurovascular bundle lies in a protective valley, the walls of which are formed by these two muscles, and the floor by the head, neck, and shaft of the humerus. The axillary perivascular technique of brachial plexus block consists of an injection into the axillary sheath, which will confine the injected solution to the axillary perivascular space, through which most, but not all, of the terminal nerves of the plexus will pass.